Are you with me? Okay, big yay if you want me to start now. Okay. So here we are with Ophthalmic Premier League Mallu edition. Let me first call the four captains. I know you're familiar with the team names. We have Trivandrum Machans. Let me call Dr. Sahasranamam, the captain of Trivandrum Machans, up on stage. Sahasra Machan on stage.
Raise your hands.
Woo! And next, let me call the Kochi Bros captain, Dr. Mahesh Gopalakrishnan. And next we have Trishur Gadis, headed by Dr. Andreos. And from up north we have the Calicut Chunks, headed by Dr. Srini Edakalan. That's the four team captains for you. I'm your host and referee for the evening. First, we'll take some law. That's my chair. What are you doing? One minus point. Okay, so first we are going to take lots to decide which team is going to come in first. And the team introduction will be along with the whole presentation. They will introduce their own teams. Let's go. Okay. Who's one? Okay, Kochi Bros is going first. Trishur Gadis going second. And Calicut Chunks going third. And Trivandrum Machans last but not the least.
ഇപ്പറഞ്ഞ നാടിന് കരയേഴു മൊട്ടുക്ക് പേര് കാണണമെങ്കിൽ കാണണം കടി ശിവദേവൂര്
ബിരിയാണി കഴിച്ച പിന്നെ സംഗതി നല്ല ഉസാറ് കൽബില് തേനൊഴുകണ കോഴിക്കോട് നല്ലേ വേട്ടയനല്ലേ
Shall we start? Yes. So according to the Lords, judges please note, Kochi Bros is going first. Kochi Bros is going first. Sir, the team in the voting. I request Kochi Bros to be on stage. One minute. Captain, yes. Do you think you will win?
Definitely. We are here to win only.
Are you not worried about the pitch?
No. We have all types of players. We are going to win.
Okay, let's wish them all the best as they start their innings. That's Kochi Bros for you.
This will work, no?
And timer on for 14 minutes.
1 minute. They have not started yet.
No,
So
it's on the video.
Coach
The
intro.
whole thing is recorded on a video.
Yeah.
First 14
No,
minutes.
PowerPoint. Fine.
He's playing Praveen Pawar.
Yeah. It's fine. It's fine. Okay. Audio? Yeah. 44.
കരിനീലക്കായലുകൊണ്ട് കരമുണ്ടും ചുറ്റിട്ടും കാർമേഘച്ചെപ്പിൽ തൊട്ട് മഷിക്കണ്ണിലെഴുതിയിട്ടും
നീരാഴിക്കാറ്റും കൊണ്ട് നിന്നീടും പെണ്ണാണേ കനവാലെ കോട്ടയും കെട്ടി അവളങ്ങനെ നിപ്പാണേ
പറയാമാ പെണ്ണിൻ കാര്യം 17 പ്രായം
നേരാണ് നമ്മടെ കൊച്ചി ഇവ നമ്മടെ മുത്താണേ പറയാനുണ്ട് നമ്മടെ കൊച്ചി കഥ ചൊല്ലാൻ പലതാണ്.
Welcome to the magic of 3D printing innovations by Kochi Bro JD. Imagine a magic 3D printer that can be used to make ophthalmic innovations. And imagine that the manual for that is there in the Kerala Journal of Ophthalmology. These are some of the 3D printing innovations which I have done in ophthalmology. Let's look at the eye drop guide. This is a basic design, and this allows a bottle to be placed in it and placed on top of the eye of the patient such that the drop falls directly into the eye. This is very useful for elderly patients who find it difficult to use eye drops. Video is available in the QR code. Another one is the punctal plug. This one was designed, printed using resin 3D printer, and the design we have made it available in the Thingiverse website, and this was published in the Indian Journal of Ophthalmology as well. And this is a design done with the help of two very innovative MBBS students also. Another device which I have done was the 3D printed glaucoma drainage device, which was designed in FreeCAD, and these are some of the designs. And the one here is an Orolab aqueous drainage implant. We implanted this in a cadaver goat eye for wet lab practice. The video is available here, and the designs are available in the Thingiverse website. Then another device which was done was the MIGS implant and instrument. So that was the Kahoot dual blade and the eye stent. The video is available here, and these are the 3D printed devices. These are printed in large size for teaching purposes. You can also use augmented reality to view all these 3D models which I have uploaded using the Merge 3D app, which can be downloaded from this QR code. And you can use your phone to look at any of the 3D models which you have added, and then move it around in real time using a cube made out of A4 sheet paper printed with this design. Then let's look at eye surgical instruments. So we have designed a few eye surgical instruments, including a phaco probe, chopper, irrigation aspiration, IOL, and even a BHEX ring. The designs are available here and they can be 3D printed for wet lab purpose or training purpose. These can also be put into your PowerPoint presentations as I have done here. Another one is the cataract surgery big model innovation, and this was used for teaching phacoemulsification steps. And these are the 3D models. The yellow is the nucleus, blue is the trypan blue stained anterior capsule, and orange is the red globe. The foldable fundoscope, which is a device which is used to take fundus photographs. And this is the first design which I drew in FreeCAD, and then it was 3D printed as a working prototype. And then a newer model was designed which had inbuilt illumination and also magnetic docking of the phone, and that was then patented. And that also won an award for a startup challenge. These are the innovations from the Kochi Bros. Thank you.
Coming to the surgical magic, let's begin with the first case. Here is a grade 2 nucleus sclerosis. I'm very well nicely going and doing the capsular rhexis. Hydrodissection is done, and I'm proceeding ahead very comfortably with my phacoemulsification. I rotate the nucleus, do my first chop, and things are going very fine. The OT is going very nice. I'm so happy. Up comes the nucleus, and I'm chopping it. Everything is proceeding quite smooth, and here's the end of the nucleus management, and I begin the capsule management further for the cortex aspiration. Ouch, look at that. Could you see the, yes, there it is. The PC has started to come up and it is folding up. Oh my God, look at that. Is there a rent? No, it's just the folds. Wait, what should you do? You should just come out and let the irrigation remain and put in the viscoelastic. Push that PC behind. Yes, there it goes behind. And now we need to go at the other end. Now we need to be proceeding very carefully. I'm removing some of the epinucleus and taking care of the cortex here. The PC looks fine over there. Things are okay. My heart is beating faster now. The PC could come up, the whole back could come up. And oh, look at that. The whole PC is popping up. And you can see that the whole PC is fluctuating very badly here. The PC is actually rolled up onto the anterior capsule. I remove that, and now we need to inject a lot of heavy viscoelastic here to push the PC behind. I'm walking on a tightrope here, but you can see the anterior capsular margin is intact. That means the anterior zonules are intact. So we put in a CTR, we rail it in, we use the double hand technique, use 2 dialers, and you can see it is so very well demonstrated here that yes, in goes the CTR, and the PC is nicely gone behind. Wait, there's more. The capsule is not, rhexis is not that good, so I'm going in and enlarging the rhexis a little bit. And in comes the 3-piece IOL, and I'm going to put it in the sulcus and do a nice optic capture. And that saves the day over here. Can you see that optic capture? So beautifully done. Yes, that ends the case. And coming to case 2, this is a Morgagnon mania. You can see a white cataract here, and I'm expecting a lot of fluid. I inject viscoelastic, I take a nick, but oops, there is no fluid coming out. So what's happening? Oh, there's a little bit of fluid there. That means there is more of fluffy cortex there. So we are using the double rhexis technique. I'm enlarging the rhexis with my micro-rhexis forceps. Mind you, it is in the left hand right now, but the direction is not good. So I change my hand, I switch out to the right hand and get a better grasp, and the direction is going well. I don't want the rhexis to run out here. So be a little careful, be gentle, keep pulling it inwards, put viscoelastic, flatten the capsule there, and yes, there we have a good rhexis. You know, don't need to do hydrodissection, just rotate it, and you know now that the nucleus is going to be dense and very, very mobile. So just do a central core, rotate it slowly, let the cortex remain, it is going to give you some cushioning. I drill, create a nice central hole over here so that I can have a good grasp. I take a grasp and I have to do a horizontal chop. I go with my chopper and yes, there comes the first horizontal chop and a good crack. So I rotate the nucleus slightly, I again go and do a horizontal chop, and yes, you have a crack again over there. Mind you, the PC is completely exposed below, there is no cortex whatsoever, so you have to be extremely careful that you're not touching the PC with your chopper. So here I have a cartwheel-like appearance, all sub-chops done, and now's the time to eat up the nucleus. Remain in the safe zone, put some viscoelastic, protect your endothelium, and chop. All the nuclear pieces can be comfortably eaten up over here. So this is a Morgagnon cataract for you guys, managed beautifully over here. And let's see this. Yes, the last piece is also out. Little bit of cortex, and that goes out very well. And here comes a single piece IOL. It's going to sit there pristinely into the bag, and that ends the case. So I have presented 2 cases to you in 4 minutes. I hope you are taking some good points out of it.
Good evening. I'll be presenting on multiple colored vials seen here. A good medical case. So it's a 22-year-old female who came to me with sudden loss of vision. So that was the only history, and there was no other relevant history. Most important part was it was a Saturday. The best corrected visual acuity, right eye was 612, left 69. Rest everything was normal. Fundus was normal, but since the vision was 612, I suspected something at the fovea, went ahead with OCT, and what you see is defect in the outer layers. What is the first DD we think about? It's always photic retinopathy. But then I asked in detail about the history to the patient. He was not giving any history of exposure to light, solar eclipse, welding, nothing. Was not knowing what is the diagnosis. Just started on multivitamin, teardrops, called him after a week, reviewed after a week, and wow, at 1 week, everything was normal. 6/6, OCT is normal, fundus normal. I didn't understand what is a DD because there was no exposure to light. And later on, I forgot in the routine OPD, seeing all mild, moderate NPDR, doing lasers. A few weeks later, a young male again pops up. Same thing, poor vision, no other relevant history. Vision 6/9, both eyes. Anterior segment was normal. Fundus, however, the OCT, however, showed outer retinal defect in both the eye. It was beautiful. The diagnosis always is usually a photic retinopathy. But this patient didn't have any exposure. No exposure to light, no exposure to sun, no eclipse, no welding lights. What could be the cause of such presentation? Is photic retinopathy the only differential? Should be we aware of any other differential? What is the cause of focal disruption? This was all rotating in my eye. I was asking the patient again and again, do you have any other thing? Suddenly he comes up that, yeah, it was a Saturday morning when I didn't see. Friday we had a party and we all used something called jungle juice during the party. I was not knowing what is it. So my go-to this is always a fields. Why fields? I get a time around 30 minutes to 1 hour to go do a Google, read about it. What is jungle juice? And there you see multiple colored bottles. They are known as jungle juice, ectasia, liquid gold. So in colloquial language, it's also known as popper. They are basically inhalation product used for recreational product. Provides a brief rush of euphoria and arousal. In most part of the world, they are legal to purchase, but they are illegal to sell for human consumption. They are widely used in night clubbing community. We all are busy in our OPD, so we don't know what is actually night clubbing community. They all happens on Friday night. The drug is very cheap. It's around 3,000 rupee. You can share among 10 people, so it comes to really 200, 300 bucks. Yeah, the advantage of this is, yeah, you can just break the bottle, you put it in the tissue or napkin, and suddenly it starts popping. It starts bubbling. That's why it's known as popper. So they are basically volatile nitrates. And in the OCT, what you see is nothing but just disruption in the outer retina, also called as popper retinopathy. Most patients this have denial to direct visualization to light, and the possible cause of damage is at present not known. My first patient came for follow-up. I asked in detail. So what she told? She also uses this drug, and she's a chronic user. So why this drug which has come having this finding? Maybe due to any recent change in popper, or as we all sitting here, we don't know what is the diagnosis when outer retinal defect is there, and we just label them as photic retinopathy. So as ophthalmologists, we should all ask patients who have unexplained foveal yellow spots with defect on the OCT, just ask about any inhalation of poppers. Vision loss, thus the vision loss after intake of popper is considered to be a very rare event. However, when you see internet, lot of people have told about the phosphine changes. So the last but not the least slide, these are all for the masculine gender here. We have something popper in form of nice whiskey shots also, and not for the male part, for the female or the fairer sex also, we have something in pink bottle which is called lady poppers. Thank you.
If we win, we are arranging popper for the banquet today. both this. Executive committee is
What I
arranging
want-
officially pauper.
So, judges, they have finished well on time, but what I want to know is how many of you had it when you came here today? I felt they were a bit more euphoric than normal.
Yeah.
Okay. So, this is OPL Mallu edition. So, this is a normal OPL. They have done their presentations. But Mallu edition, oru change vende namukku. Alle? Vende? So, in this, I am going to ask 3 questions to the non-playing captains, and they have to answer it right.
I can
The
discuss with
first-
them?
Huh?
I can discuss with
No,
them?
no discussion allowed. It's non-playing captain alone. And any help and prompting from the other side will be...
Negative mark.
Yeah, negative marking.
Yeah.
So I'm going to ask 2 questions which have correct answers. So if it is a correct answer, I will show a 4. And if it is a wrong answer, I will show out. Okay. And the third question is a subjective question. So the judges can decide whether it's 3 marks for that question. Depending on how they answer, the judges can decide how much marks you want to give them. Dr. Mahesh, ready to go?
Yeah.
Okay. Your first question. What does the Malayalam word paravaram mean?
Paravaram.
Paravaram. No prompting from the audience, negative marking. Paravaram.
Paravaram means sea, no? Samudram or something like that.
Excellent answer. Okay, so he got his Malayalam correct. Now let us see if you know a little bit of dialects. So what does the word Kolasheri mean? Kolasheri in Kochi. In Kochi
Kolasheri.
area, Kolasheri. No
Kolasheri
prompting.
is, in the Fort Kochi area.
In the Fort Kochi area, எங்க இருக்கு?
எங்க இருக்கு அதான்.
No googling, no.
It is actually Portuguese something in Fort Kochi area.
Portuguese something in the Fort Kochi area.
Kolasheri.
No.
No, actually I think
Okay.
no, I
So 1 mark and second mark is not there. Okay. What is it? Anybody knows? Hole. No.
If no one answer, we should get the marks.
Nobody knows it.
Mason. Yes, who said that? Excellent. Balamani madam. Excellent.
Mason, what is that?
The thing tekan ubhayokina. Mason
okay,
tekan
okay.
ubhayokina. That is what is Kolasheri.
Okay.
Okay.
Great.
So that was your Mallu questions. Now for your situation question. Is Mallika here, by the way?
Yo.
Mallika undo? The wife? No. Appa you can
She's
answer.
there, she's there, she's there.
She's there. So, it is your anniversary, wedding anniversary. ഉണ്ട് കുറച്ച് വർഷം മുന്നേ. So you have booked for a movie at 6:30 with your wife, and you're winding up OPD at 5 o'clock, and you need to go home, pick her up. She must be like, she has to get ready, and then you have to go for the movie at 6:30. Okay, and then the reception calls and says, Doctor, Nayanthara has flashes of light.
Wow.
Flashes of light in her eyes. Can you see her? There is no senior retinal surgeon. Giridhar sir avadi illa. Yeah. No senior retinal surgeon there. Only your fellows are there.
I will send them off also. I will send them off also. I will send them
Will
off.
you?
Fellows. I will send them off.
Will you? No. Attend to Nayanthara and dilate her and have a look at her flashes of light, or will you go
I'll pay
to...
my-
You want a scientific answer or a situational answer? I have 2 answers, 2 substantiation. One, Nayanthara will come only once in a lifetime. And flashes are emergency. So I will book a ticket at 9:30 for the cinema and see her and then go with her.
Okay, that's fine. Oh. Well played. Mallika, is that okay with you? Or will you say, oru choolum undu? Waiting with one chool. Okay, so that is Kochi Bros for you. Big hand please to Kochi Bros. we have Trishur. Let me have the Trishur Gadis on stage.
Download from djsur.in.
So we have the Kochi Bros on stage. So Captain.
Definitely, we came only to win. That is okay, but trophy will be for Trishur Gadis, no doubt. That you already offered. That will have in the banquet. We'll share with you, because you will. I am sure you will not take it. So that also I will share.
Okay, so we'll go on to your presentation. Oh, dance on. 14 minutes. 14 plus, okay, plus minus 1, that's fine. Okay. Trishur Gadis on stage.
India is facing an unprecedented catastrophe. A surge in complex ophthalmic cases is overwhelming our healthcare system. The government has taken swift action, forming a special task force called RAY. And I have been entrusted to lead this mission. I am Dr. Andrews, a senior ophthalmologist with decades of experience in managing challenging cases. My task is to guide a team to unravel the most complex ophthalmic mysteries. Let me introduce you to the incredible team. Meet Dr. Rohan Sherlock, a consultant ophthalmologic surgeon at District Hospital Palakkad. With a deep commitment to community health, Dr. Rohan is an analytic expert in tackling community-oriented ocular diseases while conducting groundbreaking research to improve public health outcomes. Next, we have Dr. Shaji Singham, an eminent corneal and refractive surgeon at a Bait Eye Hospital. Known for his fearless approach to the most intricate surgeries, Dr. Shaji has earned a reputation for tackling complex corneal cases with unparalleled precision. Introducing Aswathi Rai, an assistant professor at Government Medical College, Thrissur. As an academic expert, Dr. Ashwati is renowned for her exceptional precision in diagnosing complex clinical cases and a sharp eye for detail. Her expertise in solving intricate medical puzzles makes her an indispensable part of our mission. Let us shine a light on the darkness and give India the gift of sight. The first presentation is by analytic expert, Dr. Rohan Sherlock, who will elaborate on his team's innovative approach to screening retinal diseases.
റോക്കറ്റ് വിടാൻ പറ്റാണ്ട് വിഷമിക്കണ സയൻറ്റിസ്റ്റ് പുകവലിക്കുന്ന ആള് ലൈറ്റർ കൊടുത്ത് റോക്കറ്റ് പറപ്പിക്കണ്. ശാസ്ത്രലോകത്ത് അത്ഭുതങ്ങൾ മിന്നി മറിയണ്. കണ്ണ് തള്ളിയട ഉണ്ണിയെ സാധാരണക്കാര്. പുതിയ മോഡല് ഒരു മെഷീൻ, അതിൻ്റെ ബാറ്ററി കേടായവേ, ചാർജും പോയവേ. പണിക്കാരൻ ബാറ്ററി വെയിലത്ത് വെച്ച് കൊടുക്കണു. ചൂടാക്കിയാൽ ചാർജ് ആവുന്നൊക്കെ പറയണു. സമൂഹത്തിന്റെ താഴെ തട്ടിലുള്ളവർക്ക് എത്തിക്കാനായില്ലെങ്കിൽ then what is the use?
We have started our mobile teleophthalmology a decade before the COVID era. It was inaugurated in the year 2012. In the best, we have the video conferencing system. We have a non-mediatrix fundus camera, digital imaging slit lamp, and video indirect ophthalmoscope. In the best, we don't have an ophthalmologist as such. The optometrist will be doing all the work. The optometrist will do the preliminary checkup, and imaging will be done from the best. The images will be sent to district hospital, and where the ophthalmologist will be seeing it, and those who need teleconference will be brought inside the best. We usually conduct our camp in Grama Panchayat and CHCs and PHCs where the connectivity is there. Here we can see our tele-ophthalmology room at District Hospital, Palakkad. This is the video conferencing we do with the patient, and you can see the quality of the sound, and it is as good as communicating the patient in your consultation room.
നല്ല തണുക്കനെയുള്ള മുറിയിന്ന് പാവപ്പെട്ടവർ ഇരിക്കുന്ന ഇടത്തിലേക്ക് അവരുടെ കണ്ണുകളുടെ ആഴങ്ങളിലേക്ക് എത്തണൂന്ന് സർക്കാർ ആശുപത്രിയിലെ ഇത്ര വലിയ പരിപാടിയൊക്കെ ഉണ്ടാ. ഇഫ് there is a will, there is a way. ഓ നടക്കും. പാലക്കാട് ഇതേ കൊറോണയുടെ 10 കൊല്ലം മുമ്പേ തുടങ്ങി. കുടിലുകൾ, കണ്ണു കാണാത്തവർ, കാഴ്ചയുടെ യോഗത്തേക്ക് എല്ലാം നേടിയതിന്റെ മുഞ്ചിരി.
The patient who need further examination and treatment like OCT and green laser is being called to District Hospital. We have the vitreoretinal surgery unit also there. Here you can see a vitreous hemorrhage with pre-macular hemorrhage being removed, and another patient where posterior dislocation of the lens has been removed. The graph is, definitely shows that the major number of patients doesn't need to come to the hospital, and wherever there is video conferencing system, we use the video conferencing. Otherwise, the report will be sent telephone to the patient. Here you can see that the patient who had real-time video conferencing reported the patient promptly than patient informed through the phone. And patient is satisfied with the video conferencing information given by the staff, and most of the time they are satisfied. The patient responds that times it is time saving, it is convenient, and near about 100% believe that it is more economical.
കോഴി കൂകിയാ നേരം വെളുക്കുവോ? വെളുക്കുവോടമാനെ ഓ കൂകണ്ടതുപോലെ കൂകിയോ എങ്ങനെ ഗന്ധ വെളുക്കാത്തത്? ആ പക്ഷെ തോപ്പിക്കാൻ വേണ്ടി കൂകരുത് കേട്ടാ. സംശയിക്കണ്ട ഉണ്ണിയെ, തമിഴ്നാടിനോട് ചേർന്ന് കിടക്കണ പാലക്കാട് തന്നെയാണിതും. അതിനൊക്കെ ലക്ഷങ്ങൾ വരില്ലേ തങ്കോ? ഇല്ല, പാലക്കാട് അതും ഫ്രീ ആണ്. വർഷത്തിൽ 1-2 നടക്കുമായിരിക്കും അല്ലേ? 1-2 അല്ല, മാസത്തിൽ തന്നെ 10-12 നടക്കൂടമാനെ. ഇന്ത്യ ഗ്രാമങ്ങളിലാണ് ജീവിക്കുന്നത് എന്ന് ഗാന്ധിജി പറഞ്ഞിട്ടുണ്ട്. ചൊവ്വയിലും ചന്ദ്രനിലും ഗവേഷണം നടക്കട്ടെ. പക്ഷേ കണ്ണുകളിൽ വെളിച്ചു എത്തിക്കാനേ പുതിയ സാങ്കേതിക വിദ്യകളൊക്കെ സാധാരണക്കാരിൽ എത്തിക്കണം. അതിന് റോക്കറ്റിന്റെ ആവശ്യമൊന്നുമില്ല, സാറ്റലൈറ്റും വേണ്ട. നല്ല മനസ്സുണ്ടായാൽ മാത്രം മതിയടമാനെ, നല്ല മനസ്സുണ്ടായാൽ മാത്രം മതി.
We have done a descriptive comparative retrospective study with respect to diabetic retinopathy, and we have published in a peer review journal. And as of now, we have conducted 934 camps, and mobile teleophthalmology is gaining more of importance, and this is the best method to reach the unreached without compromising your routine work at the hospital. Thank you.
Up next is the remarkable Dr. Shaji Singham.
Ladies and gentlemen, presenting to you a delightful fusion of cinematic humor and surgical precision. And oh please, join us for the hilarity of those filmy dialogues that play at the back of our mind while doing the surgery.
He will unravel the intricacies of managing a complex traumatic and mature cataract requiring precision toric IOL implantation while showcasing the finesse of restoring pupillary function using the cutting-edge single-pass 4th row pupilloplasty technique.
എന്റെ ദൈവമേ, നിങ്ങൾ ഇതുവരെ പുറപ്പെട്ടില്ലേ? പുറപ്പെട്ടിട്ട് അരമണിക്കൂറായി. കുറച്ചും കൂടി നേരത്തെ പുറപ്പെടണോ? അരമണിക്കൂർ മുമ്പേ അവര് പുറപ്പെട്ടിട്ടുണ്ടെന്ന്. വേണമെങ്കിൽ ഇനിയും നേരത്തെ പുറപ്പെടാമെന്ന്.
കൊല്ലാതിരിക്കാൻ പറ്റുമോ? ഏവം പുലിയല്ല, പുലി എന്ന് പറഞ്ഞാൽ വെറും പുലിയല്ല, ഒരു സിംഹം.
വീണ്ടും നിങ്ങളോ?
ഇതൊക്കെ എന്ത്? നീ തീർന്നു. ഇത്ര അഹങ്കാരം പാടില്ല. നീ തീർന്നു.
തീരുമ്പോ പണി തരാൻ ഞാൻ എന്താ കുപ്പിയിട്ട് വന്ന ഭൂത?
നീ അറിഞ്ഞ ഞാൻ പെട്ടു.
തള്ളി വീട് അയിലസ.
പോരട്ടെ.
കുറച്ചും കൂടി മതിയല്ലോ. നാഹി എന്ന് പറഞ്ഞാൽ നാഹി. ഓരോ ഹേ
ഞാൻ പൊട്ടിക്കാൻ പോകുന്നു. ഇപ്പൊ പൊട്ടിക്കും. അടുത്ത നിമിഷം പൊട്ടാൻ പോകുന്നു.
ഇയാള് പോയില്ലേ? ഇടി വരവ് വെച്ചു. വകുപ്പ് ഏതാണെന്ന് പറഞ്ഞില്ല.
പോണവൻ തല്ലിയവൻ. പിടിച്ചോ.
ഇതല്ല, ഇതിനപ്പുറം ചാടി കടന്നവനാണീ KK ജോസ്. എവിടെയോ എന്തോ ഒരു തകരാറ്.
ഇബ്രാണി വിരൽ 4, തള്ളവിരൽ മടക്കി നേരെ തിരിച്ച്.
Step 1, we have a proximal iris where we enter and a distal iris where we exit. Step 1, make a stab incision at the distal iris, which is the distal incision. Step 2, a 10-0 protein is passed through the opposite side, which is the proximal incision. This is then passed through the proximal iris and left in situ. Step 3, a 26 gauge needle is passed through the distal incision through the distal iris. Step 4, the 10-0 protein is passed through the 26 gauge needle and railroaded through the distal incision. The suture is then pulled through. Now it's important to know the suture tray as it passes through the iris. It has 5 parts. Part 1, external to the proximal incision. Part 2, proximal incision to the proximal iris. Part 3, proximal iris to the distal iris. Part 4, distal iris to the distal incision. Part 5, external to the distal incision. A loop of suture as depicted in the picture is taken from the part 2 of the suture tray and pulled out through the distal incision and made to lie on the conjunctiva. Part 5 of the suture trail is then cut and passed through the loop 4 times, hence showcasing the 4 throws of single pass 4-throw pupiloplasty technique. Now to tie the knot, we take hold of part 1 and part 5 of the suture trail and pull them away from each other, and this pull will bring in a helical pattern to the single pass 4-throw.
Next, we have Dr. Aswathi Rai with her keen eye for detail and understanding of neuro-ophthalmology, the diagnosis in a complex case of optic neuropathy by deftly navigating through a range of possible diagnoses.
ഒരു നീണ്ട കഥ, നീണ്ട കഥ. ഇതാ പിടിച്ചോ. എന്താ ഇതിന്റെ കഥ? ഒരച്ഛൻ, ഒരമ്മ, 2 കൊച്ചു കുഞ്ഞുങ്ങൾ, ഒരു കൊച്ചു കുടുംബം. അതാ വീട്ടിൽ നിന്ന് ഒരാൾ പ്രത്യക്ഷപ്പെടുന്നു. പ്രത്യക്ഷപ്പെട്ട 2 ബോംബ്.
A few years later.
വായിക്കണം. എന്തോ എഴഞ്ഞു നീങ്ങണു. ഇപ്പൊ വായിക്കണം. പറ്റണില്ല. വായിക്കൂ. പറ്റണില്ല. അക്ഷരം അറിയാമോ? അറിയില്ല. ഏത് മറവിലൊളിച്ചാലും ഈ അരച്ചുമൂട്ടി അപ്പുക്കുട്ടൻ നിന്നെ പുല്ലുപോലെ കണ്ടുപിടിക്കും.
ചെന്നപ്പെട്ടത് ഒരു പഴയ സിംഹത്തിന്റെ മടയിൽ.
പൂരങ്ങട പൂരമുള്ളൊരു നാട് നമ്മുടെ നാട്. ഓണത്തിന് പുലിയിറങ്ങണൊരൂര് നമ്മുടെ ഊര്. ഇപ്പറഞ്ഞ നാടിന് കര 7 മൊട്ടുക്ക് പേര്. കാണണമെങ്കിൽ കാണണം ശിവപേരൂര്.
And the patient finally reached us. When we examined him, we could see that his right eye was perfectly normal, but in the left eye, his vision was reduced to 1/60, the color vision was defective, and his pupil showed a relative afferent pupillary defect. We did a fundus examination and could see that the disc in his left eye was edematous, the field depressed, but the macula was normal. And we also sent the patient for a VEP, which showed that the P100 potential was significantly delayed from the left eye, which was suggestive of a left anterior visual pathway dysfunction. Then we decided to do an MRI, and in the MRI, the intraorbital portion of the left optic nerve was found to be swollen with increased signal intensity and contrast enhancement. But there was no evidence of demyelination, tumor infiltration of the central nervous system, or cerebral venous sinus thrombosis. So provisionally, we reached a diagnosis of left optic neuritis. The tab imatinib that the patient was on was stopped, and he was started on injection methylprednisolone 500 mg IV BD.
നിങ്ങൾക്ക് വ്യക്തമായി കാണാമോ? വ്യക്തമായി കാണാം. Okay.
So we discharged the patient on oral steroids, and tab imatinib was restarted after 1 month. But within 7 days, the patient's vision in left eye again dropped to 612 and disc edema reappeared.
ഇനി
And we decided to do nothing except keep the patient under observation. The tab imatinib was again stopped, and miraculously, in 10 days, the disc edema completely resolved and the vision again became 6/6. Imatinib-induced optic neuropathy can occur at any time after initiation of treatment, and the first step in management of a patient on imatinib presenting with vision drop is withholding of the drug. But before you make a diagnosis of imatinib-induced optic neuropathy in a patient with CML, it is important to rule out other intracranial causes of optic disc edema like demyelination, leukemic infiltration of the central nervous system, or cortical venous sinus thrombosis.
കേരള ഫയർഫോഴ്സിനും ഇവിടുത്തെ നാട്ടുകാർക്കും മണവാളാൻ സ്ഥലത്തിന്റെ പേരിലും എന്റെ വ്യക്തിപരമായ പേരിലും ഞാൻ നന്ദി രേഖപ്പെടുത്തിക്കൊള്ളുന്നു.
Together, we are Team Ray. Retinal Analysis Yielders, a team united by our commitment to restore sight and bring hope to those who need it the most. The road ahead is challenging, but with the skills and determination of this team, we are ready to face it head on.
Polichello gadis.
ഞങ്ങൾ പൊളിക്കാൻ വന്നാണല്ലോ.
ആണല്ലോ. അപ്പം ചോദ്യം ചോദിക്കാല്ലേ? പിന്നല്ല. അപ്പൊ ഈയിടെ വന്നൊരു പാട്ടാണല്ലോ പൃഥ്വിരാജിന്റെ ലൈലാഗമേ. ഈ ലൈലാഗം എന്താണ്?
ഞാൻ സിനിമ കാണാറില്ല.
കാണണ്ട. ലൈലാഗം. ലൈല മേഡം അല്ല. അയ്യോ പാവം മേഡം, അങ്ങനെ പറയല്ലേ. ലൈലാഗം. ചോയ്സ് ഒന്നുമില്ല സാറേ. ക്ലൂ ഇല്ല. നോ ക്ലൂ. എനിക്ക് മഹേഷ് എന്നെ ഓടിയിട്ടിട്ട് തല്ലും. അപ്പം
വിട്ടു.
ഔട്ട്. അടുത്ത നമ്മുടെ ഡയലക്റ്റ്. എളുപ്പമാ. കൊള്ളിയാൻ.
ആകാശത്തെങ്ങ് മിന്നുന്ന ഇതല്ലോ, ഇടിമിന്നൽ പോലെ വരുന്നത്.
ഓക്കെ. അപ്പൊ അത് കിട്ടി. കൊള്ളിയാൻ is minnal in Trivandrum dialect. Okay. So that brings us to the end. ജയിക്കൂ.
തീർച്ചയായിട്ടും.
ഒരു ക്വസ്റ്റ്യൻ കൂടെ ഉണ്ട്. Sorry. Oh, Lailagam is the poet has just converted it into Malayalam actually for lilac flowers.
അത് ആ ക്വസ്റ്റ്യൻ വിഡ്രോ ചെയ്യണം. വേറെ ക്വസ്റ്റ്യൻ തരണം. ആർക്കും അറിയാം, ഓഡിയൻസ് പോലും അറിയില്ല.
It's a very famous song. It was asked on radio. What is the meaning of Lailagam? For a long time on Radio Mango.
റേഡിയോ ഒക്കെ
റേഡിയോയും കേൾക്കത്തില്ല, സിനിമയും കാണത്തില്ല. എന്താ സാറേ ഇത്? Okay, so now സാറിന്റെ ക്വസ്റ്റ്യൻ ശ്രദ്ധിച്ച് കേൾക്കണം. യു ആർ മാഡം വന്നിട്ടില്ല. You can choose between being the best cataract surgeon forever and being young forever. What would you choose and why?
I should be young forever. ഇപ്പോൾ അങ്ങനെ തന്നെയാണ്, മരിക്കുന്നവർ അങ്ങനെ തന്നെ ആയിരിക്കും.
സർജറി പോയി തലേട്ടെ.
സർജറി ഒക്കെ വിട്ടു.
ഓക്കെ സർ, ശരി. താങ്ക് യു സോ മച്ച്. താങ്ക് യു. ബിഗ് ഹാൻഡ് ഫോർ തൃശ്ശൂർ ഗഡീസ്.
അപ്പൊ സമ്മാനം ഞങ്ങൾക്കല്ലേ?
അവിടെ Team number 3, Calicut Chunks, Kozhikode Chunks.
DJ RB mix. Kalagachia.
Raise your hands.
Square. Yes.
Timer on.
Right, running man and video on. Audio on.
The Kozhikode chunks, first we'll have Dr. Jason, then Prithvi, followed by Indu.
In the field of ophthalmology, most surgeries, be it retina, glaucoma, cornea, whatever it is, can be repeated as often as you like. Unfortunately, cataract surgery is the only surgery you cannot repeat. When patient becomes pseudophakic, cataract surgeon becomes jobless. This is a case of hypermature cataract. She was advised cataract surgery and she readily agreed for surgery, but she mentioned that she had already undergone cataract surgery 5 years ago. Dilated evaluation gave me a surprise, a pacification of whole of IOL, including optics and haptic, giving a pearly white appearance to the IOL. This is the second case reported. This is the other eye of the same patient. This is the third case. Here, the fourth case, here you can see numerous fine granular deposits in the anterior surface of the lens, sparing subcapsular lens area and the haptic. This is the fifth case. In this lens, this is the lens offering, this is the case of hydrophilic lens. All cases are hydrophilic lens and primary surgeries were done elsewhere. This is a lens offering this special feature. This lens makes cataract surgery repeatable. Your assumption is not correct. This is not from Kudangulam. IOL opacification is a rare complication, typically affects in the late postoperative period, more common in hydrophilic lenses. All above mentioned cases were reported 4 years after surgery. Opacification are made of calcium and phosphorus complexes that accumulate on the surface and subsurface areas. Exact causes are still unknown. Primary calcification is associated with impurities in the IOL biomaterial or issues with the IOL packing. In our reported cases, 3 were looking like primary IOL opacification. Secondary opacification is because of disruption of the blood aqueous barrier, for example, postoperative uveitis. Exposure of hydrophilic IOLs to the air, as seen in DSEC and DMEC, with intracameral injection of gas, is another reason for IOL opacification. Systemic factors include renal failure and diabetes. Pearly white IOL opacification can be easily mistaken for white cataract or PCO, which is otherwise known as secondary cataract. For this reason, the term tertiary cataract is often used for IOL opacification. So the take-home message is, choose your IOL partner wisely. Make sure that it is a perfect match for long-term clarity. This is the second case reported. Here I couldn't extract lens, I couldn't save the capsular bag. Lens was extracted with the bag, and it was brought into the anterior chamber and extracted. Finally, I was forced to opt for a iris claw lens. Thank you.
സ്റ്റാരിങ് നേരെ പിടിക്കും. ഇതൊന്ന് നേരെ പിടിക്കാൻ ആദ്യം വല്ലതും കൊടുക്കണം. അനാവശ്യമായിട്ട് സ്റ്റാരിങ് അങ്ങോട്ടും ഇങ്ങോട്ടും വെട്ടിക്കില്ല. ഞാൻ പറഞ്ഞിട്ടുണ്ട് ഗിയർ മാറുമ്പോൾ ക്ലച്ച് അമർത്തണമെന്ന്.
അപ്പൊ ആക്സിലേറ്ററോ?
അത് പിന്നല്ലേ.
ഓ അത് ശരി. അപ്പൊ ക്ലച്ച് ഇടുമ്പോ ഗിയർ അമർത്തണം അല്ലേ?
ഒന്നാം ഘട്ട ക്ലച്ച് കുഴിച്ചെടുക്കുമ്പോൾ ഗിയർ വലിച്ചു എടുക്കണം.
അപ്പൊ ബ്രേക്കോ?
ബ്രേക്ക് ഇടുന്നതിലും കൂടി പണ്ടാൻ അടിക്കാൻ ശേഷം. ഇത്ര ബുദ്ധിയില്ലാത്തൊരു മനുഷ്യൻ എങ്ങനെ പഠിപ്പിച്ചെടുക്കാനാ?
അധികം ചൂടാവൊന്നും വേണ്ട.
ബ്രേക്കിന് ബ്രേക്ക്
എവിടെ? ബ്രേക്ക് എവിടെ?
ബ്രേക്കിന്റെ ഞാൻ എവിടത്തെ കാര്യങ്ങൾ
Retinoscopy is an objective refraction technique to estimate a person's refractive error and is the primary and integral step to a complete ocular examination. Despite the presence of excellent literature and animated videos on the retinoscopy technique, learning this art is a challenge as there is no simultaneous observation of the retinoscopic reflex obtained from the patient's eye by the mentor to the observer.
Simple. Java വളരെ simple ആണ്. Powerful. ഭയങ്കര powerful ആണ്. അല്ലേ? പിന്നെ safe. Java വളരെ safe ആണ്. മനസ്സിലാവുന്നുണ്ടാവല്ലോ? അഞ്ജലിക്ക് മനസ്സിലായോ? മനസ്സിലായില്ലെങ്കിൽ പറയണം. കേട്ടോ?
Shall I? Hence, we thought of an idea. What if we could attach a smartphone to the retinoscope, just like how we attach it to a gimbal, which is used by a photographer to take stable videos? This gave rise to the gimbal scope. These were the materials required. 2 commercially available smartphone holders were attached using cyanoacrylate superglue. The holder is then attached to another clamp, which is passed through the battery handpiece of the retinoscope and fixed tightly. The smartphone is attached to it, and its camera is then aligned to the eyepiece of the retinoscope, and the whole setup is reinforced. This setup is of immense benefit to beginners, as they can better understand the reflexes and observe them with their mentors in real time, as well as utilize the recorded video in identifying and appreciating the abnormal and subtle retinoscopy reflex. And the smartphone zoom could be used digitally to magnify them at the same working distance. These are a few recorded videos of the retinoscopy reflex using the gimbal scope.
രംഗച്ചടം കാണിക്കുമെന്ന് പറഞ്ഞാൽ കാണിക്കും.
ഇപ്പൊ ടെക്നിക്ക് പിടിക്കും.
Here starts the saga of Mrs. X, titled From Swell to Smile, a Let's Journey. This was her in 20s, young and pretty. Noticed a small swelling in right upper lid. Slowly but progressively increased till her pregnancy, when all of a sudden it enlarged, caused total closure of her right eye. People mocked at her, causing her much despair. She went to many doctors and was taken up for surgery twice in 2 prestigious institutions. But alas, surgery had to be abandoned twice due to profuse bleeding. Years later, it hit her harder, growing enormously, and now she had come to my OPD. On examination, I found it was not just a mass. Oh my God, that was a pulsating mass. With her pulsations, I could feel my heart throbbing. Previous surgeries ending in a bloody mess was obvious. It was a large arteriovenous malformation filling the entire upper lid, extending the superior orbital rim. Enlarged vessels in the lower lid, hypertrophied eyebrow, scar of the previous surgery. MRI with MR angiogram showed an ill-defined lesion with prominent phlovoids and periorbital region extending to scalp, supplied by superficial temporal artery and draining to angular vein, and this confirmed AV malformation. What do I do now? Open up and deliver this live baby? Never. It would be catastrophic eronic postpartum hemorrhage. Who can turn this pulseless, I thought, and yes, the idea struck me. I called up my chunk, Mr. Interventional Radiologist, and he said, digital subtraction angiography was performed, and this is the external carotid artery angiogram showing AVM nidus supplied by the branches of superficial temporal artery. Percutaneous embolization using N-butyl cyanoacrylate glue along with endovascular embolization via superficial temporal artery was performed. And this is the angiogram post-procedure showing obliteration of same. Now she has returned to me with same large mass. Unlike normal, I was glad that it was an intrauterine death. Now, the ball is in my court. Meticulous pre-planning with the help of a fastidious and diligent anesthesia team, including the arrangement of blood, was done. We approached via a blepharoplasty incision, and the mass was delivered out with meticulous, careful dissection and serial ligation of remnant feeder vessels. Histopathology examination confirmed AV malformation. AVMs are developmental hematomas with an abnormal nidus of dysplastic vessels with feeder arteries, draining veins, and no intervening capillaries. According to Scobinger classification, our case is grade 2 AVM. Current management options are based on hemodynamic characteristics, vascular anatomy, and location. Surgical excision is challenging and carries significant risk of intraoperative bleeding and morbidity. There are a few reports managed with combined approach by interventional radiology and surgical excision with excellent functional outcome and cosmesis. And scarce are the reports of AVM that have been successfully excised directly. And back to our story. This is what we could offer Mrs. X. Her at immediate post-op, 2 weeks, and that's her at 1 month. She is in cloud 9, and the story ends happily.
കുറച്ച് കോമാളി കളിച്ചാ മതി എന്ന് വിചാരിച്ചാണ്.
പൊളിച്ചു, രംഗണം പൊളിച്ചു. ക്വസ്റ്റ്യൻ ചോദിക്കട്ടെ?
അതാ പറഞ്ഞത്.
തല്ല ആളെ വിടുവോ? അമ്മാനെ വേണ്ട കേട്ടോ. ക്വസ്റ്റ്യൻ ഈസ് നിമ്നോന്നതങ്ങൾ. വണ്ടി വിടുന്ന തോന്നണ എന്നെ ഇടിച്ചിടാൻ. പിടിക്കവളെ, കെട്ടവളെ. No, 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 no prompting, no prompting, no prompting. Okay.
Vittu.
Vittu. Ayyo, sorry, out. Okay. That is ups and downs, hills and valleys, uyarcha tazhcha, all of that. Yeah. Next question for dialect is piyanikka. Piyanikka. Piyanikka.
വിട്ടു
പോയി. Piyanikka is excellent. Mathanga. Piyanikka is Mathanga in Trivandrum. Trivandrum സത്യമായിട്ടും നിങ്ങളാ ടൈപ്പ് അല്ലല്ലേ? ഓക്കെ ഓക്കെ. സോ യുവർ തേർഡ് ക്വസ്റ്റ്യൻ, ഇത് എളുപ്പമാണ്, സിമ്പിളാണ്. യു ആർ സ്ട്രാൻഡഡ് ഓൺ an island. You can choose who you want to be stranded with. Who would you choose and why and why and why?
ഭാര്യ മതി.
ഭാര്യ മതി. നിവർത്തിയില്ല.
ഭാര്യ മതി. എന്റെ ഭാര്യനെക്കാളും ഒരാളെ ഞാൻ കണ്ടിട്ടില്ല.
ഓ എനിക്ക് പൊളിച്ചു. ശരി. So that is the end of their 3 questions. Thank you, Kozhikode chunks. Audience, are you having a good time? You enjoying the videos? A lot of nostalgia from all those movie scenes. And we have the last team on stage. Trivandrum Machans.
Start? Yeah.
Start and
Ready, boys. Please come on.
നമസ്കാരം. എന്തരാണല്ലേ?
അടിപൊളി ശിങ്കമാനട അയ്യാ സ്വാമി ഉടമണിയാറ്റിയോടും നാട്ടുകൂട്ടം അക്കം പക്കം പാണ്ടിമേളം പാട്ടും കുത്തും പക്കവാദ്യ തപ്പും തകിലും നാട്ടുകൂട്ടം കൊട്ടിപ്പാടുന്നേ.
ഇതാണ് ഈ പേലയുള്ള ഒരു കാര്യം.
പക്കവാദ്യ തപ്പും തകിലും നാട്ടുകൂട്ടം കൊട്ടിപ്പാടുന്നേ.
അതുകൊണ്ട് കൊടുക്കാനുള്ളതും കിട്ടാനുള്ളതും ഒക്കെ കണക്ക് തീർത്തിട്ട് പോയാൽ മതി. നിന്റെ കൊട്ടാരം അമലോകം വരെയാണെങ്കിൽ അതുവരെ. എന്തേനു ഏവം പുലിയാണ് കേട്ടാ. പുലി എന്ന് പറഞ്ഞാ വെറും പുലിയല്ല, ഒരു സിംഹം.
പാണ്ടിമേളം പാട്ടും കുത്തും പക്കവാദ്യ തപ്പും തകിലും നാട്ടുകൂട്ടം കൊട്ടിപ്പാടുന്നേ.
തള്ളേ കലിപ്പ് തീരണില്ലല്ലേ. പോടെ പോടെ പോടെ.
So friends, Trivandrum Machans. So first comes our youngest Machan, Chinna Machan, Shishir Machan, Dr. Shishir Varghese. So though he is young by age, by his surgical skills and innovations, he is a Periya Machan, big Machan he is. So over to our Chinna Machan.
Same video continue. Thank you, sir. What do you do?
Same video to continue. Don't change. Lila, go back. No. Why did you minimize that?
Technical glitches.
Yes, play.
No,
തീരണില്ലല്ലേ. പോടെ പോടെ പോടെ.
So hello everyone. So as you know, in vitrectomy you need 3 ports and 25 gauge. You need to go in through the ports. We need multiple instrument exchanges, cutter. You need to sometimes use forceps for different steps. You need scissors. And you also require cautery, especially when you're operating on PDR cases. And you also require endo laser for most of the surgeries which you do. So we require frequent instrument exchange and a fast instrument exchange in vitreoretinal surgeries. And sometimes, you have to switch on the microscope light, especially when you want to go inside because you cannot see where the cannula is. You have to switch it on and then you have to go inside. But some situations come when, the bleeding is so intense, you don't know what to do at that time, and then you freeze, and then you have got to go inside fast, and you need to cauterize the bleed. And even after cauterizing it, you end up in these situations where it just goes on continuously bleeding. You again need to re-cauterize it. But again, the microscope light, once it's off and the room lights are dimmed, you cannot find where the port is. So now, after putting the cautery, see, it's not even cauterizing because a huge clot has formed over there. And that's when you realize, that what am I doing? It's like that. And then you go back home and you cannot cry to your wife, you can cry to another vitreoretinal surgeon, this has happened. So that got me thinking what to do. One day when I went home and I saw my son dancing like this, and then that gave me an excellent idea as to what can be done. So here the problem is, The microscope light is on, there are 3 ports, we can go in when the light is on, but once the light is off, we need to switch it on again, and then again only you can go inside with the instruments. So we needed constant illumination, which was not possible, and microscope light needed to be switched on and off. So we wanted a 3D printed frugal tool, you know, which could provide a constant illumination. So ready, set, let's glow. So introducing to you, this is the glow port. So this is a 3D printed ring or phosphorescent device which can be easily fitted onto a 25 or a 27 gauge trocar cannula. So it's easily fitted over there, as you can see, and then once you do the 3 ports, you can put in the glow ring onto your 2 ports, and you can charge the glow ring with your endo illuminator. There, you can charge it, the endo illuminator, 15 to 20 seconds. And once you have charged it and then you go in, you can see it glowing in the dark. And this very good for presbyopic surgeons. And once it glows, you don't need to switch on the light. Even the room lights can be dimmed, and it's easy for instrument exchange. As you can see, just charge it again and then you easily see it glowing in the dark. The innovations from Kochi Bros and Kannur tends to ignore vitreoretinal surgeons. So this is for you. Yeah. So fast remaining off glow, efficient instrument exchange, reduced ocular touch errors. And that's it. Again, the glow port glowing in the dark there. So 3D printed frugal tool, good source of illumination, smooth exchanges, reduction in touch errors, and reduction in procedure time. Beneficial for both experienced and neophytes. Thank you.
Next comes our Achayan Machan, Dr. Biju John. And Dr. Biju John, he's a very avid cricketer. But the problem is, he drops too many catches. But even though he drops too many catches, he knows how to recover. Whatever he drops or somebody else drops, he knows how to recover those drops. So over to Achayan Machan, Dr. Biju John.
Yeah, this dropped catches, whether in cricket or ophthalmology, is actually entertaining for the viewers, but it is torture for the dropper. So my head for your entertainment. Sometimes it is just due to bad judgment, like this one. I am responsible for this cataract, but my problem with judgment was in judging the size of the wren which I had actually made. I thought it was small and I could manage a phaco, especially if I am using a horizontal phaco, no rotation, no hydrodissection. But here I realized that my judgment is not correct. There is not PC support. So I just try to bail out. So this is a special maneuver discovered by me in order to test whether gravity works inside the globe or not. See, it works, I told you so. Now proceeding to vitrectomy after IOL implantation in the sulcus. It's only a small piece, I can easily remove with fragmentome. So anyway I am inside, so I get some time to do a fill-in PRP also. Now celebrating too soon is a mistake, and that is the reason for many drop catches like this. Oops, that's gone. Now here I think that I have this metal foreign body piece nice and square, nicely aligned, nothing can go wrong now. I am just coming out, oops, now foreign body. But luckily for me, it got stuck in this sclerotomy pot and I could remove it with a larger magnet, so no problem. Okay, dropping one's own weapon can sometimes be hilarious as well as dangerous to the person who is standing behind. That is why he has got a helmet. Now, here I am injecting PFCL in order to flatten the retina during the vitrectomy, and there goes soft tip. But the PFCL is acting as a helmet for the retina, so no problem. I just keep on doing what I am doing, injecting the PFCL, flattening the retina. Now I am going to deal with that soft tip. I just catch hold of with an engrasping forceps. At one end it is pliable, it can be easily brought out, no problem, so no damage done. Divine intervention sometimes helps us. Look at this catch, he is trying to save his life, not thinking about dropping his catch. But where is the ball? It has landed inside his pocket. Divine intervention. And that is a legal catch. He claimed the catch, batsman is out. Okay, this is a badly traumatized globe. There is the foreign body. This is the second foreign body that I am bringing it out. Already it is 1.5 hours. There is still one foreign body, I am removing that. I just want to get out of here and have a nice sleep because I am really tired. And now there comes another foreign body dropping from above. Now that is a vicryl piece which I had used to pre-place this sclerotomy, and that is going round and round, along with my head is also going round and round. Now what, this cannot be happening to me. So I just closed my eyes and prayed for some time. And when I removed the biopsy, I can't believe my eyes. That vitrectomy, that vicryl suture, it has made a safe landing right on top of that foreign body. Isn't this divine intervention? Now, with trembling hands, I am removing that vicryl piece. And after that, the foreign body also. Now, after these drops, we are heartbroken. But this Kochi, Kozhikode, Gadis and Chunks, they ask cruel questions sometimes. Like this.
I didn't get an answer to my question.
Don't repeat this mistake.
I can only have this answer.
ഞാനൊരു സത്യം പറഞ്ഞ് വിശ്വസിക്കൂ.
നീ പറടാ.
എന്നാ എനിക്കത് ഓർമ്മയില്ല.
And finally, it's our award Machan. Dr. Minu Mathan. Minu has got a lot of walls built in his house to keep his awards. Like the Padmanabha Swami temple walls, at Trivandrum, he has got walls in his house. But he says he keeps only awards there that we do not know. He will not tell you how to open those walls, but he will tell you to open some of the hidden walls of the posterior capsule. So we'll hear what he has to say.
So in this era of super specialty, there are some people like this who do cataract, glaucoma, everything together. I enter and tell Machu, don't do. Pala prasham paranju noki. Ariyakan. They don't sing. Finally what happens? See, the IOL is there inside trap. So we have to go in. So cataract. So I go in and see what happens to this lens. This is a single piece foldable lens kept in the sulcus. Young patient. After I explant it and see that there is a lot of fibrosis on the anterior capsule and the rexus is also very shrunken. So I try to peel off. Small areas of gaps are there, but still it is very, very strong. But glaucoma surgeons underestimate innovative fellows. They punch a trabeculectomy ostium and punch a hole in the anterior capsule also there. So luckily for me, that hole got me space to get viscoat inside and I could inflate the whole bag. And from there, I could cut the rexus margin there and initiate a rexus on the anterior capsule, or covering the fibrosis also, and get over to the other side. And once I reach the other side, the fibrosis is also coming off. But I reach there, there is fibrosis still there, but still the viscoat can go underneath that and you can separate it and cut it off. So now I am relieved. And I try to peel off the whole thing just like that, but suddenly I see that there is a gap in the posterior capsule there. So then, no problem, we create again a posterior capsular rexus, including this fibrosis, and take this whole thing out. Visual axis is clear. I take the 3-piece IOL and get it into the capsular bag and make sure that this capsular rim is overlapping on this. And so everything is done well. അത് കഴിഞ്ഞിട്ട് ആശാൻ താഴെ കിടക്കുകയാണ് ഇപ്പോഴും. സോ അവരുടെ അടുത്ത് അണ്ണന് കാര്യം മനസ്സിലായി എന്നാണ് തോന്നുന്നത്. നന്ദിയൊക്കെ എന്നോട് പറയുന്നുണ്ട്. സോ ഐ സെഡ് ഐ വിൽ ബി ദേർ ഫോർ യുവർ നെക്സ്റ്റ് കേസ്. അടുത്ത കേസ് വിൽ സി. So ഇതിന്റെ ഓപ്പോസിറ്റ് സൈഡ് ആണ് ഇൻ ദ era of super speciality. There are some other fellows like this, retina fellows. They do not want cataract surgery. Don't implant IOL. Poor prognosis. Refraction is our bread and butter. But then cataract, it is our chore, rice. So rice, if you want, go and tell them. And so after 6 months, SOR or 612 vision come, please place IOL. Again, so I go inside, see 360 degrees almost posterior synechia. So, but there is a small area where I can see that there is no posterior synechia, so I release that, put viscoat underneath the iris, and then through the PI also, they do some PI also. So the PI also, I release it gradually, and with forceps I could release and I could expand the capsular bag. So now I am trying to find out where I can find an opening to go open up the capsular bag. See, capsular bag is the ideal place to place an IOL. So I try very hard, I cannot find a cleavage plane, but then I see that there is a small opening which is created there, probably by removing the posterior synechia. That small tear has happened, but that is good for me. So I put in again viscoelastic through that, viscoat goes in and expands the bag. I change direction and pull the edge of the anterior capsule and the rhexis is created and the bag keeps on opening. I change the location and inject viscoat on the other side and open completely, but then I find that the fibrosis is not that easy to separate there. Don't be too much of a, don't have too much of a problem. Place the lens into the capsular bag. And once I place the lens into the capsular bag, a single piece lens can be folded and easily placed into the capsular bag and it centers. The center of the piece is very clear. And toward next time these VR guys tell you no IOL, no, you call me. We will help you through. Fine, thank you.
മച്ചാനെ, എൻ്റെ മച്ചാനെ. കൊള്ളായിരുന്നു സാറ്. ഞാൻ വെച്ചിരുന്ന ചോദ്യമേ ആകെ പ്രശ്നമായി. സാറാണെന്ന് ഓർക്കണമായിരുന്നു. ആ, ഞാൻ ഔട്ടായോ എന്നൊരു സംശയം. മാർക്ക് തന്നാൽ മതിയോ? എന്നാലും ഞാൻ ചോദിക്കാം. സാറ് പറ. കരതലാമലകം. മലകം. മലകം. കരതലാമലകം. അങ്ങോട്ട് തിരിഞ്ഞു നിൽക്കും മച്ചാന്മാര്.
കരമാണോ തലമാണോ എന്നറിയാൻ വയ്യാത്തൊരവസ്ഥ.
അയ്യോ, അത് കൊള്ളാം, അത് കൊള്ളാം. നല്ല ഇമാജിനേഷൻ. പറഞ്ഞോ, പക്ഷെ പോയിന്റ് ഇല്ല. Correct. In other words, നെല്ലിക്ക. പക്ഷെ അതിന്റെ ആക്ച്വൽ മീനിങ് എന്താ? ഇഡിയോമാറ്റിക് മീനിങ്. ചൈൽഡ്സ് പ്ലേ. സോ ക്ലിയർ. ചൈൽഡ്സ് പ്ലേ. അതന്നെ കരതലാമലകം.
അത്ര വ്യക്തമായിട്ടുള്ളത്.
കറക്റ്റ്.
അപ്പൊ അർത്ഥം പറഞ്ഞേ.
അർത്ഥം പറഞ്ഞില്ല.
അതിന്റെ വ്യാകരണം ഉൾപ്പെടെ പറഞ്ഞു.
ഇല്ല 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 ഇല്ല. നമ്മുടെ ട്രിവാൻഡ്രത്തെ കൂറ എന്നൊരു വാക്കുണ്ട്. കൂറ എന്ന് വെച്ചാല് മോശപ്പെട്ടത്. പക്ഷെ കാലിക്കട്ടില് കൂറ എന്താ സാറേ? കാലിക്കട്ടില് കൂറ.
കാലിക്കറ്റിലെ കൂറ എന്ന് പറയുന്നത് മറ്റേ ഈ കോറ തുണിയല്ലോ ആണോ?
കോറ സാരി, കോറ ഓർഗൻസ.
അല്ല, അങ്ങനെ അല്ല. കാലിക്കറ്റിലെ കാര്യം തിരുവനന്തപുരത്ത് ചോദിക്കരുത്.
അങ്ങനല്ല ചോദിച്ചത് എല്ലാവരും. അങ്ങനെ ബാക്കിയുള്ളവരുടെ ഡയലക്ട് നമ്മൾ അറിയണമല്ലോ. അല്ലെങ്കിൽ അവിടെ ചെന്നിട്ട് ഈ കൂറ എന്ന് പറയൂലേ, നമ്മള് തെറ്റിപ്പോവില്ലേ? ഔട്ട്. എന്താ കൂറ? പാറ്റ. പാറ്റ. വെറും പാറ്റ. ഓക്കെ. ഇനി സാറിന്റെ ക്വസ്റ്റ്യൻ ആണ് പക്ഷെ ആക്ച്വലി എന്നെ കുഴപ്പിച്ചത്. അത്
ഒരു വിദ്യാർത്ഥി അധ്യാപനം ചോദിക്കാം.
അതെ സാറ് ഒരു 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 35-40 വർഷം മുന്നേ ഒരു യങ്സ്റ്റർ ഇൻ കേസ്.
15 വയസ്സുള്ളപ്പോ?
അല്ലല്ല, 10-15 വയസ്സല്ല, ഒരു 35 വയസ്സ് കുട്ടിക്കോ. അപ്പോൾ യു ആർ ഗിവൺ എ ചോയ്സ് ബിറ്റ്വീൻ ബീങ് an Indian president and KSOS president. What would you choose and why?
Indian president.
Why? എല്ലാ KSOS മെമ്പേഴ്സ് ഇവിടെ ഇരിക്കുന്നത്.
അല്ല, KSOS മെമ്പേഴ്സ് ഇരുന്നോട്ടെ. KSOS മെമ്പേഴ്സ് ഇപ്പൊ ഞാൻ ഇവിടെ ഒരു കേസ് മെമ്പറായിട്ടിരുന്ന അവർ എഴുന്നേറ്റിക്കോ? ഞാൻ ഇന്ത്യ പ്രസിഡന്റ് നിന്ന് അവരെല്ലാം എഴുന്നേറ്റ് നിൽക്കും. അതെ, പിന്നെ എനിക്ക് വേണമെങ്കിൽ KSOS പ്രസിഡന്റും ആകാം. തിരിച്ചു വന്നിട്ടേ
ആദ്യം ജയ് ഹിന്ദ്, പിന്നെയാണ് ജയിക്കുന്നത്.
ശരി, ഓക്കെ ഓക്കെ. So that was my 3 questions to Trivandrum Machans, and with that we come to the end of the show. I hope the judges are ready with their judgment. Audience, I hope you've been enjoying yourself. But we have ഇപ്പൊ തൽക്കാലം പോ മച്ചാന്മാരെ, വിളിക്കാം ഞാൻ. So we have, all of you have keypads on your seats. Kindly pick up your keypads. We are going to vote for audience choice. ഇനി ഓഡിയൻസിന് ഒരു ക്വസ്റ്റ്യൻ ചോദിക്കട്ടെ. While the judges and the rest of them get ready, ആർക്കെങ്കിലും സ്വിച്ചിന്റെ മലയാളം പറയാമോ? സ്വിച്ചിന്റെ മലയാളം. സ്വിച്ച്. വന്ന് ഫ്രണ്ടിൽ വന്ന് പറയൂ. മൈക്ക് കൊടുക്കും. അവിടെ ഒരു മൈക്കുണ്ട്. കറക്റ്റായിട്ട് പറയണം, പ്രൊനൗൺസിയേഷൻ ഉൾപ്പെടെ. നോ, ഷീ കെയിം ഫസ്റ്റ്. പ്രൊനൗൺസിയേഷൻ ഒക്കെ കറക്റ്റ് ആയിരിക്കണം.
വൈദ്യുതി ആഗമന നിഗമന നിയന്ത്രണ യന്ത്രം.
എക്സലന്റ്. ഇനി ഒരു ക്വസ്റ്റ്യനും കൂടെ. ആഗമന നിർഗമനമാണോ? എന്നാ ഒന്നുകൂടെ പറഞ്ഞു.
വൈദ്യുത ഗമനാഗമന നിയന്ത്രണ യന്ത്രം. ഗമനം മീൻസ് കമ്മിങ് ആൻഡ് the other one is going. ഗമനാഗമന നിയന്ത്രണ യന്ത്രം.
ആഗമന നിഗമന യന്ത്രം എന്നാണ് ബുക്കിൽ എഴുതിയേക്കുന്നത്. അതുകൊണ്ട് എൻ്റെ പ്രൈസ് രമയ്ക്ക് പോകും. അടുത്ത ക്വസ്റ്റ്യൻ, എത്രാമത്തെ എന്ന് നമ്മൾ ചോദിക്കൂലേ അല്ലെ? മഹേഷ് എത്രാമത്തെ KSOS പ്രസിഡന്റ് ആണ്? ആ എത്രാമത്തെ എന്നുള്ളതിനെ ഇംഗ്ലീഷിലാക്കാമോ ആർക്കെങ്കിലും? ഗൂഗിൾ ചെയ്യരുത്. എത്രാമത്തെ, ഹൗമെനിയത്തെന്ന് ഉപയോഗിക്കാതെ എത്രാമത്തേനെ ഇംഗ്ലീഷിലാക്കണം. പ്രാഞ്ചേട്ടൻ്റെ ക്വസ്റ്റ്യനാ. യെസ്, someone is volunteered.
What is the ordinal position of Mahesh sir as the KSOS president?
Ordinal position of Mahesh sir as the KSOS president. അത്ര ഇംഗ്ലീഷ് അങ്ങോട്ട് ശരിയാവണില്ല.
ഓർഡിനൽ പൊസിഷൻ, അതാണ് അതിലെ മെയിൻ തിങ്.
ഓർഡിനൽ പൊസിഷൻ എന്ന് പറഞ്ഞാൽ പറ്റത്തില്ലല്ലോ. നമുക്കിപ്പോൾ മഹേഷ് എത്രാമത്തെ KSOS പ്രസിഡന്റ് ആണെന്ന് നമുക്ക് ചോദിക്കണം. അപ്പൊ അതിനെ ഒന്ന് ഇംഗ്ലീഷിലാക്കൂ, കറക്റ്റ് ആയിട്ടാക്കൂ, ഗ്രാമർ ഉൾപ്പെടെ.
What is the ordinal position of Mahesh sir?
ആരോ പറഞ്ഞു തുടങ്ങി.
Chronological order.
ഇവിടെ പറയുന്നു.
What is the chronological order of Mahesh sir as the president of KSOS?
Chronological order of Mahesh sir എന്ന്, എൻ്റെ ദൈവമേ. Chronological order of Mahesh sir as KSOS president ശരിയാവുമോ? ശരിയാവത്തില്ല.
Ordinal position of Mahesh sir as the KSOS president. Mahesh
sir as the KSOS president എന്ന് പറയുമ്പോൾ അവിടെ ഒരു KSOS presidents ഒരുപാട് പേരുണ്ടായിരുന്നെന്നും അങ്ങനെ വരുന്നില്ലല്ലോ അതിനകത്ത്. But it's not coming in that sentence.
എത്രാമത്തെ എന്നുള്ള അർത്ഥം തന്നെയാണ് ഇതിൽ വരുന്നത്.
എത്രാമത്തെ, അത് കുറച്ചും കൂടെ ഒന്ന് മോഡിഫൈ ചെയ്യണം.
ഇംഗ്ലീഷിൽ ഒരു ഫോർമുല എന്ന് പറഞ്ഞിട്ടൊരു ഫേമസ് ബുക്ക് ഉണ്ട്, അതിലുള്ള സംഭവമാണ് ഞാൻ പറയുന്നത്.
അല്ല, അതിന്റെ സെന്റൻസ് ഓർഡിനൽ പൊസിഷൻ സെന്റൻസിലാണ് പ്രശ്നം. വേറെ ആരെങ്കിലും ഉണ്ടോ? എനിബഡി എൽസ്? ആരോ ഇവിടെ പറഞ്ഞു, ഈ കുട്ടി പറഞ്ഞില്ലേ ആദ്യം പറഞ്ഞ, അത് രണ്ടും കൂടെ ഒന്ന് കമ്പൈൻ ചെയ്താൽ കറക്റ്റ് ആൻസർ കിട്ടും. Correct. You can ask like that. Among KSOS presidents or among the presidents in KSOS, what is the ordinal position of? But I would prefer a different answer, which is what she said. പക്ഷെ അതിനെ ഒന്ന് മോഡിഫൈ ചെയ്താൽ മതി. പറഞ്ഞു. In the chronological order of KSOS president, what is Dr. Mahesh's position? Ordinal position നോക്കാം. So that kind of gives, that is a very difficult, one of the most difficult words in Malayalam to convert to English. Okay, I have used up 5 minutes. Result evade? Audience poll is coming up soon. While they're just putting it up, Dr. Bastin, Scientific Committee Chairman, has a few announcements.
Good evening all. Before they announce the winners of the OPL, we have few announcements of the free paper award sessions. The COC RetNet posterior segment free paper award session, free paper 116, Lumi indent, an economical and handy-scleral indenter come retinal transilluminator, chief and presenting author Dr. Chandana. Professor K.S. Subramaniam PG Free Paper Award Session 3, Free Paper 42, Knowledge, Attitude and Practice Pattern regarding medico-legal aspects among cataract surgery patients. Chief and presenting author Dr. Sarup K.S. Free Paper 126, to correlate clinical features vision with SDOCT's changes in patients with mild net nerve fibers. Chief and Presiding Author Dr. Remy Salim. Padma Bhushan, Dr. P. Shivareddy Award Session, Free Paper 22, Outer Retinal Microvascular Changes in MACTL Differentiating Pattern, Chief and Presiding Author Dr. Unnikrishnan Nair. Professor K. Subramanian, PG Free Paper Award Session 4, Free Paper 106, Gimbal Scope Smart Trial, Smartphone Assisted Retinoscopy Trial, Chief and Presiding Author Dr. Julie Anthony. Free Paper 105, ELOC Atlas, A Timeless Reflection of Postgraduate Life, Chief and Presiding Author Dr. Brinda K. Padma Bhushan Dr. P. Padma Shri Dr. S. Tony Fernandez Video Award Session Final, Breaking the Mold, Unconventional Techniques in Conventional Vitreoretinal Surgeries, Chief and Presiding Author Dr. Shishi Varghese. We have the scientific committee had introduced the photography competition for the first time. So we have the winners now, and the posterior segment. Okay. Yeah. Can you switch off the lights? Lights, please. So the runner-up is Starry Eyes Retina Dice, a unique case of gas plugs in Sussex syndrome by Dr. Anju Kuriakos. The winner, Rolling Curtain, Dr. Nikhil K. I request Dr. Nikhil K to receive the prize. Dr. Mahesh, the President, will hand over the prize. I request Dr. Anju to come to the stage, and Dr. Nikhil. Dr. Nikhil, as you know, there is prize is only for the winner. Prize. Dr. Nikhil? Okay. Okay.
It's not that.
No, come to the anterior segment. The runner-up is, this is iris epithesis before and after YAG laser. Dr. Ashwati Vijayan. The winner is sandwich aqueous post-dark AAC due to cleft between graft and host with aqueous by Dr. Anaswara M. John. Winner, both. Now there was another category called nature. So the runner-up is Sandhyയുടെ നിറച്ചാർത്ത്, Dr. Gauri Arvaria. And the winner is a droplet on a leaf, nature's eye reflecting the light, capturing a world of beauty in its lens. Okay. Dr. Gauri. Runner-up. Manju. Dr. Manju is here. Okay. People. The runner-up is In Search for the Lost Fishes by Dr. Ashwati. And this is the winner, blowing away his worries in bubbles, by Dr. Manoj Venugopal. Manoj is here. Okay. And now there is a prize called Best of the Best. That is a grand winner. There is a shot to the lens, accidental intralendicular injection of triamcinolone acetonide. Lights off, Yama. You can see the needle tract also. By Dr. Rohan Suresh Nainan. Dr. Rohan is here. Even though it was a first time, we had a very great response. We had 84 videos and all the videos were good. And I thank 84 photos. Sorry, 84 photos. Thank you. Thank you very much.
So we have audience poll for 3 categories. One is the best scientific video, second is the best entertaining video, and the third is best team. So we'll show you the options. All the players are not there in the options. Those who have scored high marks, they are in the options. So we are going to go ahead with best scientific video. 30 seconds to vote. You can vote in your keypad depending on the slide that is coming here. You take your keypad and you vote. Teams, teams are vote. Yes, you can start. Shall we start the timer? Everybody is ready with the keypad? Okay, start now. Please vote for the best scientific video. Time's up. Shall we show the scores now? And we have a tie. Tie between 5 and 8. So we will declare them as joint entertaining winners. Scientific winners. 5 is Dr. Indu and 8 Dr. Minu Mathan. One more vault he has to make now. And we'll go for the next. Select the best entertaining video. Oh, please wait. We will give the prize for the audience poll first. Please, Dr. Indu and Dr. Minu Mathan, please come on stage. Audience choice, best scientific videos, Dr. Indu and Dr. Minu Mathan, joint winners. Big hand for them. Next voting is for the best entertaining video. Again, your choices are here. And your time starts now. $25 again, Dr. Minu Mathan. I mean, this Minu Mathan we OPL ban cheyyam. Big hand for him, Dr. Minu Mathan, best entertaining video of OPL of Drishti 2024. And now we have audience choice, best team. Be fair. Do not vote for your people from your hometown. Be fair. Best team, and your time starts now. And tension mounting on the field. Best team. Sorry, we will go for a repoll. We need third umpire. Joint winner ne prize illa chata. Can we have a repoll? Because lot of keypads are not being used. 211 people have voted. I think how many keypads we have? 400 keypads. What audience you are? Come on, put some joy into it. 400 keypads we have. Everybody on this floor, come and take a keypad and vote. Vote, sir. Vote, ma'am. 36 and 36. I don't think they can do that. No, the addition doesn't come up to 100, she's saying. So if you can correct it there, you might get a winner. 99. No, this is only audience poll. We have judges prize where? That's what I'm asking. All the people at the back, can you come in front and vote, please? Come on, help us out here. The voting pads are only in the white chairs. Yeah, I have some movement here. More people are coming in. Okay, last one more try. If it's still a tie, we'll leave it. Okay. Anand, ready? We'll go for a repoll. Repoll for best team. Start. Timer starts now. We have 100 more votes here, more than 100 votes extra. Let's see what's happening. Do we have a clear winner or not? And Trishur Gadis win by 1%.
DJRB mix.
Let's go.
Please come on stage. Judges, can I please request you to come on stage? Judges. All the judges, please come on stage.
Download from djsoor.in.
A big welcome to our esteemed judges. And can we have Trishur Gadis on stage for their prizes? Please, to present them the prize. Please come forward. Please do the honors.
Square.
One photo with the winner. let me interview you by the time. Please come. Nobody wants to come. So, madam, how was your experience on the other side of the panel this time? For those who don't know, Dr. Padmaja Krishnan's team was the winner in last year's Drishti for Ophthalmic Premier League. What was your experience?
Like I think about exams, it's easier being the candidate than the examiner. Yes, it is, because it's far difficult. The onus of judging people who are really, really good is difficult. Whereas last year when I was performing, we enjoyed every minute of making the videos, like I'm sure all the teams did. On the other side, I enjoyed watching them, but if I didn't have to mark them. Marking Natasha was really difficult. And the biggest marks to you, young lady. You did a fabulous job.
Thank you so much. Sir, have you been to OPLs elsewhere outside the state?
Yeah, I've been doing OPLs in my state, Andhra Pradesh, and we won together I won with Srini.
Oh, okay.
Yeah, okay. And this is my first time at KSOS. I'm really enjoying it. It's a fantastic meet, and hats off to your organization. Hats off to you organizing this. I really enjoyed myself.
Thank you, sir. Thank you.
Yes, well, apart from the obvious fact that ma'am stated that it's much more difficult to be a judge than to be a participant, and it's always best to be just audience. But, you know, when I could think of not being a judge and just watch everything, it was absolutely fantastic. A lovely experience to see all these really talented performances by really scientifically talented people who are, you know, presenting things completely differently. So it was great.
I, for one, am seeing this for the first time. So it was a very interesting experience, and there must be one hell of a lot of work that goes on behind the scenes. And these guys are all looking quite professional at it as well. So obviously you've been doing this for a few years, and it's very impressive. And I think you should, you know, widen the teams and have more participation possibly. Only problem will be the restriction will be the time. Yeah.
I thoroughly enjoyed the performances. It's a memorable experience for me. I'll never forget this. And also, Natasha, the way you conducted it was really good. And I appreciate and I congratulate all the participants. Every moment I enjoyed. And the act selection of the movie clips and the dialogues, all those things were really good. And the case presentations and the innovations, everything were really good. Unforgettable experience for me. Thank you.
Thank you so much, ma'am. Thank you to all the judges. Big hand to all the judges, please. I think I'm seeing smoke coming out of Bastin's head. Introduce the judges. Let's have some self-introductions. Sir, the audience wants to know you.
I'm Dr. Sunil Thangaraj, basically a corneal surgeon, anterior segment surgeon, but the place where I work, I got to do everything. So that's it. And I'm really very much into stuff like this. I love the OPL. Thank you so much for making my trips a joyous occasion. Really, really good. Thank you.
I'm Andrew Braganza. I'm a professor in CMC Vellore. So I'm basically a teacher and, you know, well, you know what professors do. Mostly nothing. So anyway, but I make it a point to try and come to KSOS every year because I think this is one of the best conferences that there is within our country. So thanks for that.
I am A.B. Jacob. I work as a consultant ophthalmologist with a special interest in glaucoma at Southampton University Hospital in the UK. I have been a regular to the KSOS now for several years after a long gap. And the most impressive thing about this conference is that when I initially attended this many moons ago, when I was a PG or a early consultant level sort of person, when I was working in Vellore as well, it was a very basic conference. And today, I think it is very well organized. The contributions are very good, and the participation is the key to the whole thing, and I think the participation is excellent. So keep up the good work. Thank you very much.
I'm Dr. Kausalya. I'm a senior consultant in Department of Neuro-Ophthalmology in Aravind Eye Hospital, Madurai, and also I'm the clinical in charge for vision centers, the primary eye care centers across Tamil Nadu, which are attached to Aravind Eye Hospital. This is the first time I'm attending KSOS, and I said earlier it's a very nice experience. And it will be incomplete if I don't mention about yesterday's cultural program. Yesterday evening's cultural program was mind-boggling. It was really nice. All the doctors, they were all really professional, dancing, singing, and the way they dressed up, the costumes, everything was excellent. Thank you.
You'll get more of it at the banquet.
I am who I am, and the only thing I have to say is I've always heard the TONA conferences were excellent. So to get praise from Tamil Nadu that our conference is excellent is praise indeed. Thank you so much for appreciating. I didn't get the job. I went for the but they told me I got the primary at the last year. But they said they would prefer people who had graduated from psychology and clinical science, Anglo-Saxon or whatever I was saying. Actually, at that time, it was only one doctor. I guess that's true of the whole demographic profile. I hear you can walk through the streets of London and not hear a word of English.
The last. Okay, so it was like the judges said, it was very, very difficult to judge who is first and who is second and everything. But we have the winners now. Let's start with the best scientific video. The runner-up is Dr. Vanashri. Dr. Vanashri from Kochi Bros. I request Mr. Kumaran from Zivira to please do the honors. Along with Dr. Bastin. Judges, please accompany for a photo. You need to be in the background for all the photos. Don't move.
DJRB mix.
Raise your hands.
Square.
And the best scientific video of OPL of Drishti 2024, Dr. Prithvi Chandrakant. Best entertainment video as per judges' decision. Runner-up, Dr. Minu Mathan.
DJRB mix.
Let's go.
And the winner, best entertainment video of Drishti 2024, Dr. Biju John. Dr. Biju has gone for to start the GB probably. The Trivandrum Machan's Chief Machan will now receive the prize on his behalf. Big hand for him.
DJRB mix.
And we have the team with the best costume. Goes to Kozhikode Chunks. Please come up for your prizes. Kozhikode Chunks, please come up for best costume. Big hand for Anyanan and Amban. And the best promotional video, Kochi Bros. Available members from Kochi Bros, please come up for best promotional video. Again, Dr. Mahesh has gone for the GP.
Download from djsoul.in.
And finally, the best team. Runner-up is Trishur Gadis.
Raise your hands.
Square.
And finally, ladies and gentlemen, put your hands together for the best team of OPL of Drishti 2024, Trivandrum Machans.
RB mix.
Let's go.
Download from djsoul.in.
Thank you, judges. So big hand to our judges. Thank you very much, audience, for being here and being encouraging us through. With that, we come to the end of this year's Ophthalmic Premier League. I thank Bastion for giving me this opportunity. I also thoroughly enjoyed myself. And we'll see you again next year with a better edition.
Raise your hands.
Square.
Hello, hello. Thank you all the participants. It was a great show. And I take this opportunity to thank Dr. Natasha, who took the pain to conduct this program. And a token of appreciation, I request Natasha to accept a small memento on behalf of the scientific committee.
Thank you so much.
Hello. The general body is already started in Cine 1. Cine 1.